All right, it is 10 o'clock, so we'll get started. Hello, everyone, and welcome to the Healing Community Study Learning Collaborative. My name is Lisa Romley, and I am the Education Program Coordinator for the HEAL Study. We're here today to learn and discuss the implementation process of the EMS-led naloxone leave behind programs. I just need to review a few housekeeping items before we get started. Just a reminder that this session is being recorded today. And if your screen name is not your full name, you're using a partial name or you're using your phone, if you could please update that now and change it to your full name. This just helps when we compare the participants' names in the session with our registration list. We are offering CE credits for today's session. One CE credit has been approved for physicians, pharmacists, nurses, social workers, alcohol and drug counselors. And I'll give you some information on how to obtain that CE credit at the end of today's session. We are also offering certificate of attendance for anyone that wants that. We do ask that you stay on mute if you're not speaking, and that just helps reduce the echo and extraneous noises. And if you have any questions, and we do welcome your questions today, please use the raise hand feature, which you can click on reaction button and then click on the raised hand. Or you can just type your questions in the chat box and we'll read those questions during the session. Just to report, all speakers for today's session have stated that they do not have any financial relationships to disclose. And the practice gap that we have identified is naloxone represents the safe and effective standard of care for EMS reversal of opioid overdose. But delays in overdose recognition and other systemic barriers can cause EMS providers to arrive too late. Providing naloxone to individuals at the highest risk of experiencing or witnessing an opioid overdose can increase the chances of future successful reversal. And the educational need that will be addressed is the EMS response after drug overdose represents a critical point for intervention, with an individual at the highest risk of overdosing again. Providing education on how EMS can prevent or reduce the risk of future overdose may increase the prevalence of naloxone leave behind programs. Our learning objectives for today's session is describing the need for EMS naloxone leave behind programs, discussing the Kentucky administrative regulations and statutes, and identifying barriers to the program. And hopefully at the end of today's session, you'll have an understanding of the need for the leave behind programs, as well as be able to develop strategies to implement this program. So for today's session, we have Dr. Doug Oyler, who will be our speaker as well as our moderator. Dr. Oyler is an assistant professor in the Department of Pharmacy Practice and Science at the University of Kentucky. He serves as the director of the UK's Office of Opioid Safety, where he leads the institution's opioid stewardship program, including development, implementation, and evaluation of strategies to improve safe opioid use within the health system. He is currently the principal investigator on grants from the U.S. Department of Justice and the Kentucky Cabinet for Health and Family Services. Dr. Oyler is a member of the HEAL prevention team, specifically aiding with overdose education and naloxone distribution across the settings. I will now turn it over to Doug. Let's share here.
Okay. Hopefully you guys see a full screen version of the slides here. Okay, great. Well, so thank you for the introduction, and yeah, thanks everybody for joining us this morning. So yes, my name's Doug Oyler, and I'm faculty at the University of Kentucky, and I'm part of the HEAL study in the prevention team, and have worked some with Tanya and Terry and some other groups that are joining me here, who will do some more introductions later on how to try to implement leave behind strategy. So yeah, what I'm going to talk about here is essentially some different considerations when implementing these types of strategies, really specific to Kentucky, but you can maybe take some of the kind of general principles and apply them in other settings. All right, let's see. There we go. So So Lisa already went through the objectives, but the kind of general outline. So I'll talk a little bit about some of the pharmacology here as it pertains to some of the barriers and stuff that come up. So a little bit of the kind of drug pharmacology and stuff, but then what the need is for OE&D or overdose education and naloxone distribution, and then why this is specifically important in EMS and the real reasons that EMS lead behind programs can be so impactful. A little bit about the legislative authority. Again, that's going to be specific to our state, and then some other considerations for Kentucky and some of our experience, at least from a larger perspective in the first wave of the HEAL study and some of the communities that implemented these strategies. And then in our panel, we'll get into a little bit more detail about some of the considerations and barriers and individual experiences. Okay, so without getting too much into the weeds about pharmacology, I think it is important to talk about kind of how and where opioids work and introduce at least a little bit of terms that you may have been that you may be familiar with, but try to kind of put at least some of a standard definition, if you will, behind these and help make some other stuff later make sense. So we talk about opioid receptors. So there's different types of receptors and kind of the type of receptor that you have and where that receptor is located determines some of the effects of a given opioid. So the types of receptors, for the most part, we're talking about mu opioid receptors here, but there's other types too, delta, kappa, and opioid receptor-like receptors. And then where these are, so the picture here specifically looking at different mu receptors, but these are all throughout the body, but specifically looking in the brain, where these are kind of determines some of the effects that you'll get from administering an opioid that will activate, if you will, that receptor. And I'll get to that in just a second. But what you can see is some of these modulate pain, some of these modulate reward systems. Some of them are kind of your reactions and reactivity to pain. But then most importantly, when we're talking about an overdose, is this at the bottom of the picture, the brainstem here, where activation of those receptors is important in regulating breathing. The next piece is about characterizing different molecules that bind to these receptors, if you will. So there's a few ways to do this. The first is with receptor activity. So again, we're specifically talking about these mu receptors here, but with receptor activity, we have agonist and antagonist. And essentially an agonist is something that binds to that receptor and activates it. So produces the effects that go downstream. So that's the typical things that you would think about as an opioid: fentanyl, methadone, oxycodone, heroin, buprenorphine, opium, any of these kind of things. And then you have an antagonist. And what's important here is an antagonist doesn't produce the opposite effect. It just doesn't produce the downstream effect that an agonist would. So that's things like naloxone and naltrexone. So what this means here is if you give somebody who's not on an opioid, if you just give them naloxone, it's not like they're all of a sudden going to start breathing faster and be in a bunch of pain or something like that. It doesn't do the opposite. It just doesn't produce those downstream effects. And we talk about some of the side effects and stuff, if you will, of naloxone a little bit later. Kind of having that understanding is important. And then the second piece is receptor affinity. So that's essentially, kind of how tightly something binds to these different receptors. So again, when we're talking about mu receptors, at least, if you have something that has a high affinity, it binds kind of tightly to that receptor. So fentanyl, buprenorphine, naloxone, and then something with a low affinity doesn't bind as tightly to that receptor. So what that means is if you give something with a higher affinity, it could essentially kind of kick off something that has a lower affinity. So then the last piece of this is a little bit specifically about naloxone pharmacology. So naloxone has a higher receptor affinity than a lot of opioids, not all opioids, but than most of them. And so what that means is it's able to essentially kick off these agonists, an oxycodone, a heroin, a morphine, something like that. Fentanyl and some of the fentanyl analogs, they have a pretty high affinity as well. And that gets close to that naloxone affinity. And there's different kind of numeric values and stuff that we can assign to affinity. That's a little kind of too in the weeds for this, but fentanyl and things have a little bit higher affinity for this receptor. So they bind a little bit tighter than a morphine or something. And that gets kind of closer to that naloxone affinity, which means it's a little harder for the naloxone to kick off the fentanyl than it would be a codeine or something like that. So what naloxone does, it essentially knocks the agonist off of that receptor, but it doesn't produce the downstream effect, right? So that's what we mean by an antagonist. So it's not like it does the exact opposite. It just stops that process of, in this case, when we're talking about breathing, it stops that suppression of your drive to breathe. So that's how it essentially reverses, if you will, the effects of these opioids, but that does precipitate withdrawal, and that's some from the brainstem effects and some from other receptors in your gastrointestinal tract and that sort of thing. And then it lasts somewhere between 30 and 90 minutes. So the dose may need to be repeated. But essentially, that's kind of the gist of naloxone pharmacology. So that agonist-antagonist piece and the affinity stuff becomes a little bit more important when we talk about some of the barriers later on. So then, when we talk about overdose education and naloxone distribution, or OEND, so this is a twofold intervention. So the first piece is educating people to recognize and respond to an overdose. So stuff like call 911, like those kind of important steps, as well as how to administer naloxone and that sort of thing, and how to recognize here's the signs and symptoms of somebody who may be overdosing from opioids, but also how to reduce an individual's risk. So, we'll talk a little bit later about specific risk factors for an opioid overdose, but how does an individual perhaps modify behavior in some way to try to reduce their risk? So it's a little bit more than just here's how you give somebody Narcan kind of thing. And then the second piece, obviously, in naloxone distribution is physically giving them the naloxone. It's available as several different products, so 2, 4, 8 milligram intranasal products. So Narcan is the lower strength ones there. Cloxato is the higher strength intranasal product. And then there's injectable versions with or without atomizers, so that you can kind of give the injectable version intranasal. And then there's a newer intramuscular injectable formulation, which is Zimhigh. So there's a few branded products and now generic 4 milligram naloxone intranasal as well. So we look at the evidence supporting OEND as this kind of comprehensive strategy. One of the things is we know that bystander administration, so having lay people in the communities, if you will, giving naloxone increases somebody's odds of surviving an overdose by about 8-fold. And there's several studies that have looked at this over the years, and we know that communities in general that have these OEND strategies and have implemented these types of OEND strategies have less overdose mortality than those that haven't. So it works on an individual level, and then it also works in kind of a population community level as well. But that's about getting the naloxone out there. The other piece, that critical piece here, is that OE, or the overdose education. So actually up to about 1/3 of people, if you just have naloxone, give naloxone out of the community, about 1/3 of people will give it the wrong way. Most commonly, they don't actually so you have to put the device up in the nostril and press the plunger. Most commonly, they don't put the device all the way in the nostril, or they don't actually push the plunger to release the drug. But up to 1/3, even with the easier to use, like intranasal, Narcan, Cloxato, generic formulations, up to about 1/3 of the people may not do it correctly. So our educational materials in the Healing Community Study cover a lot of things. They cover the pieces of naloxone administration, but also, again, these risk factors for an overdose, strategies to prevent an overdose, how to recognize someone who may be overdosing, the appropriate steps to respond here, again, call 911, and then kind of the other things to go through this process, as well as information about, what naloxone is, how it works, those kind of things, how to actually give it specific to the products, and then how to make sure this is stored appropriately, that it's not expired, all of those kind of things as well. So moving a little bit into the importance of doing this in EMS, when we look at the risk factors for an overdose, the single most important risk factor for overdosing is having overdosed before. Right. So when we talk about implementing these kind of strategies for naloxone leave behind, these become critically important because this is the highest risk group of people. It's people who have immediately overdosed. That's the single biggest thing that predicts somebody overdosing again. Other things are, a history of substance abuse, so including whether this is prescription drugs, illicit drugs, including alcohol in this as well. Other medical diagnoses, things like sleep apnea and psychiatric diagnoses, anxiety and depression, and so forth. being unemployed, being opioid naive. Specifically, when we look at things like recent release from prison or from an abstinence-based treatment program, those individuals are at higher risk. Being in middle age seems to be a little bit riskier time as well. And then polysubstance use, so using multiple different types of depressant drugs. This would include co-prescribing things, so like opioids and benzodiazepines or muscle relaxants and that sort of thing. And then from prescription drugs as well, there's a lot of different prescription variables, high doses, specific formulations of long-acting drugs, that kind of thing. But the important take-home point here is that most important risk factor is having overdosed before. So when we talk about here's a really high-risk group, this is an important strategy to start considering. So you may say, well, why don't we just give them naloxone after they leave the emergency department? So only 1% of people fill a naloxone prescription, at least based on insurance claims and stuff. And given the cost of it, that'd be a reasonable kind of proxy for use here. But only about 1% of people fill an opioid prescription or fill a naloxone prescription within 30 days of an opioid-related ED encounter. So that'd be something like an overdose, an encounter for opioid use disorder, an encounter for opioid withdrawal, that sort of thing. So people aren't filling these prescriptions. And then even if you give them a prescription for naloxone, less than half of people who get a prescription in the emergency department are going to actually go and fill that prescription for naloxone. So that results in a lot of so we've done this at the University of Kentucky and several other hospitals throughout the state have done this as well, of these essentially emergency department based OE&D programs. So essentially ensuring that someone physically has naloxone in their hands before they leave the emergency department. So kind of put it to actually get them the drug before they leave via, a meds to beds type program or something else from, dispensing cabinets in the ED and that sort of thing. So there is that strategy, but that still relies on people getting all the way to the emergency department and kind of having that system in place there. So then looking at the opportunity with EMS, so this is just from the Healing Communities study, the 16 counties here in Kentucky, and you can get a kind of general trend of EMS events that involve naloxone administration. You see a peak here in the early phases of the pandemic in April, May of 2020. But in general, you can see just in these 16 counties, there's somewhere between it fluctuates between 600 and 1,000 events per month where EMS is in the community and there's an event at least involving naloxone administration. So there seems to be a pretty clear opportunity here to intervene, at least again in Kentucky. And the other piece of this is looking at transport refusal rates. So people that refuse being transported to the ED in the first place. So we know that transport refusal increases the risk of somebody subsequently overdosing. So it increases your risk about 60% or so of overdosing if you refuse transport on the emergency department. And patients were more likely to report or to refuse transport during especially the early phases of the pandemic. But what we have seen, and this is a little bit older data now here in the graphic, is a general trend in increasing transport refusals. So again, an increasing opportunity here. If we have a good amount of these events happening and more people seem to be refusing transport, then this would be a good opportunity to essentially leave that naloxone behind with them, because we know they're high risk and they're not necessarily going to make it to the emergency department, where people don't always necessarily get a prescription or get naloxone when they leave there anyway. So that takes us to these leave behind programs. So essentially what this is OE&D, or that overdose education, naloxone distribution, that's conducted with individuals and or their networks, so family, social networks, community, after an EMS response to an overdose. And there's a lot of different ways to do this. So we'll get into that a little bit in the panel, because I think the groups that we brought in have approached this in different ways. So to give us kind of different perspectives of here's a few different avenues to take to try to actually implement this strategy. But it provides an opportunity at least to reduce that risk, again, for the highest risk group. And the other piece is it may offer an entry point perhaps into treatment. So we'll talk a little bit again about barriers here in a few minutes. And this can be an important one. So this may offer an entry point to kind of have a bigger impact than just giving somebody naloxone right now. So the authority for this comes from KRS 217-186, and I've kind of pulled out the snippets of it here, and then a little bit later when we talk about liability and stuff, I'll come back to this specific statute. But this is the most recently revised version. It was essentially the big revisions lately were to replace the word naloxone in here with opioid antagonist to make it kind of more friendly in case other products that are opioid antidotes, if you will, become available. But so within here you have a person or agency, including several different groups, but within this, firefighter, paramedic, or EMT. Can do all of these different things, but the specific one I'll draw your attention to is D, which is provide as part of a harm reduction program an opioid antagonist to people who have been trained on the mechanism and circumstances of administration. So this explicitly allows for all of the steps necessary for it to happen, receive a prescription, process that sort of thing, but also to give that out into the community. So that's where it's explicitly allowed in Kentucky statutes. That said, there's still several other barriers to actually making this happen, and EMS folks on the call today may be kind of thinking through some of those in their heads as well. So this is a survey of about 130 EMS personnel. It was just published last year, and essentially what they did was they asked about a number of different questions, but one of the things was around barriers to implementation of these types of strategies, and kind of categorize these into one of several different groups. And we'll get into more detail here in a second, but the largest here was essentially concerns about encouraging risk-taking behaviors. So, about 29% of respondents had thoughts around this. About 20% had concerns about naloxone itself, and that's where these kind of adverse effects comes in. Concerns about not addressing the underlying problems of however those are defined, which I'll get into in a second. That was another big one. EMS-related concerns, and then cost of the drug. And then there were some other ones in there, but these are kind of the big categories. So what those are, so they then kind of broke down into each one of those categories, what actually makes all of this up. So I've highlighted the ones that were kind of the big ones from each category, or that made up, more than 5% or so of responses. So you can see concerns about increasing opioid use / addiction / overdoses was the largest concern. About 13% of people responded with that, or giving some kind of false sense of security. So we'll touch on that one here in a second, and the kind of associated moral hazard, if you will, as this is termed sometimes with making naloxone available in the community. Next, you see things around cost, as well as not addressing the underlying problem. Many times this wasn't specified what folks mean by the underlying problem, but in general, kind of community level substance use disorders and that. So we'll address that as well. And then adverse effects and some of the legal or liability concerns. We talked about the legal piece. We'll get into liability here in just a second. So considering this kind of argument of moral hazard, at least. So essentially to kind of frame this argument, the concern is that, if we make naloxone available, people use it as a safety net, or folks may use in riskier types of situations, or this just kind of encourages drug use or something like that. The evidence that's available, at least, says there's no association between giving people take-home naloxone and an increase in opioid use. And what I pulled out here, so this is a study from several years ago now, where they had about 50 individuals with a substance use disorder and looked at kind of drug use patterns before and after these individuals participated in an OE&D type of event. And what they found was there was a small population, so about 12%, so 1 in 8 or so of these individuals reported 3 months later that their drug use had increased, but over half reported their drug use had actually decreased, and then the remaining third said it stayed about the same. So, so it's possible this may happen in a smaller group of folks, but the evidence that's out there suggests that these may actually be associated with a decrease in drug use and an increase in entry into treatment and treatment retention, which starts to get at that piece of addressing the underlying problem. The next thing to talk about, though, that I think is very real and worth discussing, and we'll touch on this some in the panel, I think, as well, is essentially all the things that we ask EMS personnel to do anyway, and disempowerment as it pertains to this huge problem of the opioid crisis, compassion fatigue, and all these really real concerns. So this is the first study here. This is a little bit earlier, so this was reflects some of things around COVID. But you had about half of EMS providers in a survey, reporting compassion fatigue. The odds of suicide are double or more than double versus the general public among EMS personnel. And only about a third of EMS personnel think that they really have the power to positively impact the opioid crisis, right? And you see I've got circled here the date of this other article, 2016. So these aren't new concerns. I mean, this is pushing 10 years old almost now, of all of the other concerns that are real problems to try to wrestle with in EMS, of work hours, violence, all the other problems that folks have to deal with as kind of frontline personnel. So we'll talk more, I think, a little bit in the panel, some about compassion fatigue and such, but these are really real concerns to try to address as well. The next is about naloxone safety, and there's a few kind of big umbrellas, I suppose, of safety. Probably the one that gets the most attention would be kind of safety of the individuals administering naloxone itself, and concerns about violent or aggressive behavior and that sort of thing from individuals that their overdose is reversed. So a few points about that. So the FDA approved naloxone for overdose reversal over 50 years ago now. So we have a long, a half century of experience using naloxone for reversal of essentially opioid related effects or toxicity. It does precipitate opioid withdrawal. So there are behavioral changes that can come about from doing that. The aggression piece has really been attributed back to two case reports from the early 90s. Another study of about 450 patients or so in the mid 90s reported one incidence of, so these are people that had adverse effects from naloxone. Many times this is, withdrawal symptoms and that sort of thing, nausea, vomiting, those type of effects. One individual that reported that exhibited violent behavior, as they called it, that was possibly attributable to naloxone administration. So not to say that these things can never happen, because there certainly are reports or anecdotes of this. But this is something, it's been routinely used, post-operatively in hospitals and such for reversal of procedural sedation and those kind of things. So the prevalence and scope of it, we really don't have good evidence that says this is something that happens with X amount of frequency or anything like that. There are safety effects or safety concerns for individuals. There's other side effects and things associated with naloxone. Not many, because remember, it's essentially binding to that receptor and stopping the downstream effects, not producing new or opposite effects. But there are rare case reports of things like pulmonary edema and such with naloxone administration. Some studies suggest that these may be dose related. Others, it's a little unclear as to whether or not these are dose related side effects, or whether they'd be more prevalent at higher doses or not. The next concern to try to talk through a little is this concern about addressing the underlying problem, and specifically the underlying problem of, the prevalence of substance use disorders. Are we treating and managing folks substance use disorders, or are we just treating the most prevalent or concerning symptom about it right now? So a real concern, and I will agree that giving somebody naloxone as an overdose antidote is not a treatment of their substance use disorder. Now, interestingly, there's a few at least reports and things starting to come out, a few studies coming out of some of these pilot programs. Mostly these are in California and in New Jersey, but looking at things like EMS-provided buprenorphine as part of a multi-component treatment strategy. So essentially being able to give individuals a dose of buprenorphine to help mitigate some of those withdrawal symptoms as part of the treatment process, if you will, after an overdose reversal. So there were two big studies that have been published about this recently. One was in pre-hospital emergency care, which is the first one I've got on here. And this is a pilot of 36 patients that received doses of buprenorphine as kind of an induction treatment for a substance use disorder after an overdose reversal. 35 of them agreed to transport and were transported to the emergency department. And actually, 36% of those stayed in treatment for at least a month. So this may be one strategy that can help that. A second study, this was out of New Jersey in the Annals of Emergency Medicine, found that patients who got this dose of buprenorphine from EMS were about 5 times more likely to stay in treatment for at least a month. I'm not going to get too much into all the weeds of this. There was a separate Kentucky Open session about this. So if you want to scan the QR code there, that'll take you to this session was recorded. It's available. I think it's about an hour long or so, discussing specifically buprenorphine provided by EMS and kind of experiences with that and what that might look like in Kentucky and so forth. The next thing to talk about a little is liability. And again, we'll touch on this some in the panel as well. What I'll speak to here is, I can't speak to your, individual malpractice or liability coverage from an insurance type standpoint. But what I will say is within that Kentucky statute, so what I showed you before was Section 4, Section 5 of this is a person who is acting in good faith provides, there's also some administration here, but provides is what we're focused on. An opioid antagonist is immune from criminal and civil liability for that provision, unless this is related to willful or wanton misconduct of the individual. So there is liability built into this statute, or immunity from liability, criminal and civil, built into this statute. And then the last barrier to talk a little bit about is cost. So within the 8 Wave 2 communities for the HEAL, we're working with several different agencies to provide them no cost naloxone for a leave behind type program. Outside of those communities, in Kentucky, there's the Kentucky Opioid Response Effort, so another QR code, but you can scan that and that'll take you to their site, where essentially they're doing a very similar type of program for non-HEAL communities that's really similar to what we're doing. Essentially, they'll provide no cost naloxone for these leave behind strategies as well. So this is to kind of get in with that program through the Cabinet for Health and Family Services. So the last thing I'll touch on broadly is kind of our big experience within the HEAL and in Wave 1 in Kentucky, at least. So we had 6 first responder agencies. 4 of these were EMS agencies, 2 were fire agencies in 3 different communities in Wave 1 of the HEAL, and across those groups distributed over 1,000 naloxone units as part of their leave behind programs. And this was over, depending on kind of when folks came on, anywhere between 12 and 18 months or so. But over that 18-month period, we had 1,000 of these units that were distributed out. So a good amount of engagement with the community, and at least from a kind of big picture perspective, I would say a fairly successful type of campaign ongoing. And these groups are now working not necessarily with the HEAL, and maybe we can touch on that a little bit as we move forward, but with the Kentucky Opioid Response Effort to kind of sustain these beyond what we got started up in the HEAL. So in summary, then, before we move into our panel, hopefully I've made the case that naloxone can be a life-saving antidote after an opioid overdose. Those individuals that have overdosed recently, that's who's at the highest risk. And that's why I think EMS is uniquely positioned very well to have a real impact in reducing future overdose risks. And these programs are feasible. So I talked about our experiences in Kentucky, at least. This was essentially, we took what had been done in other states, so Arizona and other places like that, and said, how can we just implement a very similar thing here in Kentucky? So this has been done in several states across the country. So it is feasible, but there are real logistical considerations and things to think through, and hopefully we can talk through some of those on our panel here. So I think that's kind of the end of my presentation here, and maybe if I can get my computer working. So we'll move into to a panel discussion here. So I've got two folks with me to talk about their experience. If folks have questions, we can put them in the chat. You guys can raise your hand, that kind of thing as well. But we've got Terry Dunn. So Terry Dunn is the community outreach coordinator for the Boyle County Emergency Medical Services. Terry's a social worker. He's a graduate of Eastern Kentucky University. He's previously worked with Signature Healthcare as the director of social services, and he's a licensed minister of the gospel at Little Zion Baptist Church in Bergen, Kentucky. And we also have Tanya Donselman, who's an assistant director for Madison County EMS in Richmond, Kentucky. She's also a graduate of Eastern Kentucky University in their medical care program, emergency medical care program, and she's been a paramedic for over 23 years. So thank you guys both for taking some time to kind of talk through your all's experiences, and kind of maybe as we get started here, if you guys can introduce yourselves and maybe tell us a little bit about how you've been involved in the HEAL study.
Well, I'm Terry Dunn.
Go ahead, Terry. Sorry.
It's okay. I am community outreach coordinator for Boyle County. I did not actually start wave one here in Boyle County. I came in back in July, so I've been here a little over 7 or 8 months or so, but really have really felt like this is a great program. I've really enjoyed actually getting out, kind of being the boots on the ground and getting out into the community, meeting with families and, of course, individuals that suffer from substance use disorder. And it's just been a really a wonderful experience, not just for myself personally, but, for our community, I feel, and our EMS first responders.
Hi, everyone. I'm Tanya Donselman. Like Doug said, I'm assistant director for Madison County EMS. We started the program in 2020, and we've been a part of the HEAL since then. We've moved to CORE now. The way that I've been involved is I have also been a paramedic on the street that's been distributing the naloxone to our patients and family members. Prior to taking my position here, I was training coordinator for us for about a year. So I've also been part of the training portion of getting our employees on board, making sure they know how to distribute and what they need to do. So.
Thanks. So you guys touched on a little bit, but can you guys talk some, and maybe Terry, we'll start with you, on kind of how you guys got involved with the program, and maybe how difficult do you think it was to start implementing this type of program?
I think it was, our director of EMS really had a, I think even before the study, had a passion, seeing all the different overdoses that they were responding to. And so he was very instrumental, I think, in working with our judicial system and many of our community partners, just wanting to get this program in and get it implemented here in Boyle County. And I do know him, and he kind of reached out and contacted me when this position came open. And I didn't hesitate. I'm also a recovering addict as well. So I think my whole journey kind of has led me here to this point where I can give back, personally, in a sense, to individuals that are suffering, and I do relate to many of the issues that they have. It's been a good experience.
In 2020, our director at the time, Carlos Coyle, was contacted by the HEAL community. We were having a significant opioid epidemic in our community. We knew there was a problem. So we were contacted about being part of this program. We had our initial reservations. There's a lot that goes around this. There's a lot of questions, concerns. I think Doug does a really good job of explaining those to you, but we still were hesitant at first. But over time, we decided collectively that we were going to try to make this a solution for our community rather than ignoring that something was wrong, but we didn't know how to change it. And so implementing this was the first step in that process. So that's how we initially got involved. To start the implementation of the program, it was pretty seamless. It was more the convincing of the staff to get on board. The training is easy. It's a video they supply for you. So anytime I hired someone new, I've showed them a 5-minute video, went over the paperwork with them, and then went over the product that we provided for the community, and they were able to go out that day and start giving it away. It's not hard. Getting it back when you do distribute it to the community is also very easy. They fill out that piece of paper they're trained on, you fax it over to Doug, and Doug sends you product back when you're low on the product. So actually implementing in the program and going through it was relatively seamless on our parts.
Thanks. So I touched a little on, or kind of hinted at, you guys have a little bit different processes for how you guys actually kind of implement and do the leave behind after a run. So can you guys talk a little bit about what your process is looking? And maybe Tanya, we'll start with you this time. Can you guys talk about kind of what your process looks like and how you actually physically get naloxone to folks? Okay.
So after training our employees, our main goal is to reach out to the people within our community initially that were, like Doug said, overdosing, because they're our highest risk in our community to repeat overdose. So we initially, when we were on scene and starting to implement it, naloxone had been in our community a little bit, so there was some familiarity, with it, especially among drug addicts within our community. They were fearful of going to the health department to obtain it because they were afraid they were going to be registered and followed up on and documented in some way. So it became pretty easy for us to talk to them about the Narcan, talk to families about the Narcan. And what we do essentially is the box has a brochure wrapped around it for directions on how to use it, and that the Healing Project provides for us. It also has a pamphlet that has resources within our community so that they can get follow-up help if they want. That is left there too, so that if they don't want it initially, maybe the next day, maybe 3 days later, that brochure is sitting on their coffee table and they think about it. We fill the paperwork out with them, ask them a few questions, nothing that's HIPAA violation. They don't have to sign anything. And then we explain to them how to use it. It's a quick verbal, this is how you do it. Make sure they know to, like Doug said, to insert it fully into the nair, how to administer on both sides, and how to plunge the medication. We keep it pretty simple. That's how we wanted to start it in the beginning. We're looking at, of course, increasing different steps now to provide a little bit more for our patients if they want it, that option. But we kept it simple as just getting Narcan in the hands of people that need it.
Yeah, and we were similar, of course, here in Boyle County. I, fortunately had the opportunity to, in some instances, be on scene during an actual overdose. I typically would ride with EMS or our supervisor on scene. And if not, I would typically try to follow up with the individual within 24 to 48 hours following. And basically, we just had to get, kind of put together some kits that have it has naloxone in it. It has education resources on how to administer naloxone. We also have community contact resources in our community, such as AA meetings, NA meetings, different groups, different resources in the community that a lot of individuals may be facing. So we would kind of put all that information together. And as I said, fortunately had the opportunity to meet with families and meet with different individuals. And I would often conduct a live session of training along with giving them the information as well. And I would just kind of have a duplicate to show them how to administer the Narcan. I know that at one point we did have a video that was provided by the HEAL community. A lot of people kind of felt like it was too long of a video. And then as I, began to do the live sessions, it was like, as she said, Tanya was saying, it's real simple, real quick, and very informative. And even today, a lot of individuals that I sit down to meet with have never administered anything like that, or especially with the family members, the mothers and fathers and grandparents, and they really found it very useful and helpful. So I did have the opportunity to kind of meet with them. I always leave all the information and the naloxone behind. And of course, my biggest part is trying to get them with some type of treatment resource, whether it's inpatient, outpatient, AA meetings, NA meetings, therapy, mental health counseling, whatever we can do to try to link them with services to help them moving forward. Has always been my passion.
Thanks. So maybe you can build on that a little bit more. Do you have, what in your experience, Terry, has been some of the more effective strategies to actually try to link people and connect them to treatment and recovery? You went through a lot of the different things you do. Are there some that seem more effective than others?
I guess my biggest strategy really is, upon meeting the individual and trying to kind of assess their drug use, what type of drugs they're using, history, frequency, and always I end up trying to tap into, I guess you could say, a strength perspective, trying to find out what strengths that they have. I know spirituality, of course, with me being a minister, that's always, that has been a very effective tool that I've been able to use to kind of reach out to tap into what's really going on and what's really going on at the core of it for the individual. I use prayer. I've prayed with many individuals. And just I think the follow-up visits is one of the things that has been very effective. I can't count how many individuals have thanked me after the first initial visit. And I get the sense that they just really appreciate somebody thinking about them and having compassion for them, empathy for their situation. And of course, I don't always, in every example or with every case, kind of disclose everything about me. And in some cases, I may do that. But just meeting with them and then coming back and following up with them again, as I have several examples where I followed individuals for up to 2 months or longer. I'm actually working on one right now I've been dealing with for about going on a couple of months. And that individual just overdosed last night again. So, you know, it's tough. It's a tough place to be in at times, but it's very rewarding. And I just really enjoy having that opportunity to just be out in the community and getting to know these individuals. I really think it's been a very positive effect in our community.
Thanks. Yeah. And thanks for sharing that. So as a reminder to the group, we've got one question here in the chat. If folks, in the audience have questions, feel free to, you can do the reactions and raise your hand thing, or turn your camera on, raise your hand and wave and try to get attention. You're also welcome to put your questions in the chat. So we'll ask this to both or either of you here. How do you guys identify the people who need the drop-off information? So who, I guess, would benefit from the naloxone, or who need some type of follow-up?
Terry, I think that might be better for you, where you actually do the follow-up, resources for the community. We don't do the backside of that. So I think that might be a better question for you.
Yeah, and that was kind of one of the things that is kind of generated now that I'm have been provided with this position here in Boyle County as a community outreach coordinator. Of course, we were looking into basically any type of overdose or drug-related substance use runs. Typically, when I come in each morning, or even over a Monday morning, I'll go back and look at all of our run sheets. And many times I have to kind of really, they're not always what they might appear to be just looking at them from the outside. So I really kind of dig into some of them to find kind of my angle and see who would probably or more likely benefit from a visit or my services. It started out, of course, with overdoses, but we've also taken on the role of just looking into a lot of mental health cases here in Boyle County, outside of overdose cases as well. So I'm looking into really both. All of that. A lot of times those, of course, go together, mental health issues and substance misuse as well. So that's really kind of what I look for. As I said, I've really got a great staff here that's on board. They're all very supportive. I think they really even kind of get excited when I get to go with them on runs, and they've got me there. But they are, I quite often get leads from them, when I come in the next day. There may be an individual waiting, or they left me a note or a message, email, something, wanting me to kind of take a look at this particular case or particular individual. But they've been very helpful.
Thanks. So can you guys talk a little about, I essentially gave a list of here's all the barriers, but can you guys talk some about maybe what some of the barriers were when you all were implementing this up front, and how you guys address those? Specifically, again, I mentioned the concerns about liability. That's stuff that's gotten brought up some. I touched a little on the legislative piece, but maybe Tanya, will start with you. If you guys can talk about some of the barriers that you've had and maybe how you've addressed those.
Sure. Like I expressed before, we had some reservations when we were first approached with this. Is this best for our community or not? And one of the biggest things that we always look at is liability. How are we going to fall in the responsibility when we leave these to these patients and to our community? Are they going to be able to come back to us with lawsuits or accusations? What kind of responsibility are we taking? When you look at what Doug presented as far as the legislation, you are well protected. Can someone sue you? Of course they can. They can sue you for anything. What we had to do is stop thinking about it from a point of liability and start looking at that as our fears of the change and our fears of what this program is going to be giving to our community. We were uncomfortable. We're uncomfortable with the notion of let's leave Narcan and we're just going to encourage these people to do worse. Let's leave Narcan and they're not going to call 911. We had to rethink the way that we thought about it. So instead of thinking about it as a liability or a crutch for our community, we had to start thinking about it as it's a gift. So it's a gift to a mother who has a drug addict for a son. It's a gift to a grandmother who has a grandson that's a drug addict. It's a gift to a child who has a mother that's a drug addict. It's a gift to our local businesses who find someone in their parking lot that they don't know what to do with. Most of the time, we still respond. These people are going to administer it. They call 911. We go there now, these people are awake instead of waiting there and being hypoxic for the 10, 15 minutes it takes us to get there, depending on in the 437 square miles of our county that we have to respond to. It gives them power as a family member who looks at it and says, I have nothing to do. I'm doing everything that I can to get resources to my child or to my loved one or to my community, but I can't do anything in this time frame. It gives them a resource. It gives them power. The reaction you get from the families of the loved ones, it's priceless. They have something that they can do to save the people that they love, even though they can't get them in treatment right now, or they've tried a dozen times and it's a cycle. They have something in that interim to get through. So we had to start readjusting. We stopped thinking of it as a liability. We started seeing the safety that we had, and we started looking at it as a gift for our community.
Yeah, one of my biggest barriers originally was just, I think I mentioned that at one point when we talked before, but was our local hospital, our regional hospital, due to HIPAA and some other liability issues, but outside of the initial ER visit, I was not able to get in contact or come to visit individuals in the hospital. They would have to have an actual release of information. And in many cases, I hadn't met the individual, so they didn't even know who I was at that point. So, but we are working with our director and our emergency room director, who is at our local hospital. He's also our medical director. We're working to try to see if we can kind of streamline that process, see what we can do to get me in. I think that, of course, the sooner that you can get in contact with individuals is always better. It's always a good thing. We also have consent. We have an authorization for consent forms that we do have them to sign. This just allows Boyle County EMS to release information to different agencies to try to get them substance use disorder treatment. Very important in doing that as well. One of the things that we've done to try to remove some different barriers and things is once we get that release signed, we can contact different individuals at treatment facilities on their behalf. And we're able at that point, I know in several instances where I've had peer support specialists from different agencies and facilities that would come to collaborate, and sometimes we would do visits together as well, so that they could fully explain the type of services that they have. And that's just that's always been interesting as well. And the other barrier that I've ran into particularly is individuals who do not want to be transported to the hospital following overdose. In most instances, I'm not even able to get back in touch with them or find them. A lot of times they're not at their legal address. They may be at a friend's or an acquaintance's address, and I don't really have any information in those instances to try to get in touch with them to offer some type of service treatment. Oftentimes, what I do in those instances is whatever address that they were found at, I typically will try to leave them Narcan, the education materials behind there at that address. But that's pretty much the most I can kind of do when I can't get in touch with them.
Thanks, Terry. I think that starts to address some with there's a question about, identifying folks as a violation of HIPAA. I think you kind of touched on that some with the release of information. There's another question in here around, is there any kind of rule or statute in Kentucky that prevents participation of EMS in a leave behind type program? I'll say nothing that I'm aware of. The only laws that I know of are the specific laws that explicitly allow this. So I haven't seen that. And as far as being told this by K-Beams, I am not aware of any of those laws. I don't know if either of you know of any laws or rules that prevent participation in a type of leave behind program. There's nothing that I know of. So okay. Let's see. Another question might be, do you guys have, or maybe Tanya, do you have recommendations for how you might track some of the outcomes or look at, how a program's going, if you will?
Sure. So we don't keep any records specifically of like the patient's name and things like that. They're just tracked through our ESO, so our PCR reporting. I'm a numbers person, so I really like to go and look at what I can actually measure to see how the program's working. So the way that we measure it is we went back and we looked at in 2020 how many times did we administer Narcan as a service. We made in 2020 just over 16,000 runs here in Madison County, and we administered about 400 doses of Narcan. At our peak, we were spending about $25,000 on Narcan alone out of our supply budget. It was pretty bad. When we got involved with the HEAL program in 2020, you can look at our numbers start to decrease. In 2022, we've administered 256 doses of Narcan. That significantly decreased our cost resources. It's decreased by about 33% when you run the numbers. As of right now, the track that we're on for 2023, if we continue down this pathway, we're looking at even decreasing that more to about maybe an average of 200 doses given administered this year. That cuts it in half of what we've administered to our community in 3 years. So you can see those numbers. And our total run volume for this year is going to be just under 19,000 if we continue on our average. So we're increasing our run volume, decreasing the amount of Narcan that we're actually having to administer to our community. Now, what does that mean for us? It's a cost saving. It's a resource savings. And then also our community and our patients are getting that medication if they need it quicker than what we could provide it for them. So we know that the opioid doesn't itself kill the patient, hypoxia does. So if we can get that on board quicker, get their breathing increased, we're going to decrease the chance of arrest, anoxic brain injuries, things like that. So we're seeing a benefit just by looking at those numbers in our community. They're either getting it sooner or they're no longer needing our resources. So that's what we track right now. I'm not sure if we could continue to track and follow people later on. That may be a resource, kind of like what Terry's doing. But right now, that's how we're looking and navigating to see if this program is working for us as EMS in our community. And I think a decrease of 50% over 3 years of naloxone administration on our part is a pretty good number.
Yeah. We are actually, I mean, we do track, we do keep data. We keep all their, we have, of course, have ESO as well. And so all of our EMS runs are through there, but we also keep all data on the individuals. And of course, I keep all of my follow-up information. We're actually just still compiling data. Where I came in kind of halfway through the program, I wasn't able to use the data from the individual that was in this position previously. So from July of 21, now we've been organizing and keeping all the data so that we can kind of see what the results are. But we do keep everything, basically all information and case notes as well from my follow-up visits.
Thanks. So I guess the kind of last question here from my end, at least, and certainly if folks have questions, again, please feel free to put them in the chat and stuff. What would be your all's recommendations to other agencies, other EMS agencies that are interested in participating or implementing some type of leave behind program?
I think if you're interested in it and you see a need in your community, this is an amazing program to become a part of. I've got to experience over the first wave and see what it's done for our community. We now have vending machines outside of our jail that provide naloxone for our community. We have went from just providing it to the people that we respond to having people knock at our door. Local business owners want us to provide them with Narcan. We have resources throughout our community that are providing this, and people within our community no longer look at it as a taboo. It is almost sometimes an essential for them. They want to help. You will have people in your community and people on your staff that are not going to buy into this. They're not. It's hard to change people that have never or either have compassion fatigue or who have never directly been involved with someone with an addiction problem. It's hard to change their perspective. The one thing that I did notice also is with our staff, I have a young staff. I think a lot of us do now in EMS. The activism on their part of being able to do something besides just go in, wake these people up and sign them out has changed their perspective and got them more motivated and decreased that fatigue. Overall, our staff, our community, our patients, they've benefited from this. Whether you take a baby step into it and toe the pond, or you dive in and go all the way with your program, I highly recommend that you move forward with it. It's been very impactful for us, and I look forward to continuing to work with everyone and see what other kind of changes we can make in our community.
Yeah, I think it's definitely a great program, and it's definitely been a very big asset, I think, to for each county. I would like to push for social workers to have social workers in every county that are able to get out and kind of do community service and get to know individuals in the community, and kind of similar to what I'm doing. But even starting as Tanya was saying, even starting with just the naloxone leave behind, that's still a start in the right direction. I know that working with the community partners, our ASAP program here in Boyle County has just been very instrumental as well, very supportive. And we are getting a lot of different partners from our community kind of really on board. I know from this initiative, we've looked at all of our schools in our county, our school resource officers. We're wanting to make sure that they've got naloxone, all of our first responders. We've had first responders, stop by to say, hey, we're out, can we get a naloxone or, one to have on hand. So we've just really got everybody, I think, really on board and trying to utilize this. And it's really a saving grace. I spoke earlier about an individual that I've been working with that overdosed again last night, and his family, they were able to use naloxone that we had provided for them to bring him back. So and keep him at a good place until our EMS team could arrive. And so, you know, that's really what it's all about. He's really a good individual, just making some poor choices right now. And I know what that's like. I've been there before myself. So whatever we can do to give them an opportunity to change, I think it's well worth it. And I would encourage any community to adopt a program like this.
Well, thank you guys for sharing and for being part of this. Thank you everybody for taking some time to join us here. Unless there's any last minute questions here, I'm not seeing anything, but maybe Lisa, I'll turn over to you.
Thank you, Doug. And thank you, Tanya and Terry. Wonderful presentation and just sharing the highlights of your program. It was really valuable. And Dr. Oyler, your presentation was great. So I learned a lot from that. So thank you. What I'll just go over here is how to get the CE credits. And also in the chat box, there was questions about PowerPoint slides and also the HEAL education materials. I will send that out in a email, the post email that'll go out probably tomorrow sometime. So you'll get that information too. All right, so if you just need a certificate of attendance or you are a licensed alcohol and drug counselor, just visit this link. And I think Rose is putting that in the chat box for me, and fill out that information. And within less than a week, you will get your certificate emailed to you. If you are a nurse, social worker, pharmacist, or physician, you will go to this link, the CE Central, get credit, and you will enter this activity code. Again, Rose is putting that in the chat box for me. And this, if you've never filled out, attended the CE Central and got CE credit before, you will have to do a quick registration, but it's very fast and easy. And then just enter that activity code and you immediately get your certificate of attendance and your CE credit for that. And then we are interested in your feedback. Please share with us what you liked about this session. What would you like to see in future sessions? We do read these, and they are valuable as we continue on with these learning collaborative sessions. And just to kind of give you an update, our plans for future learning collaborative sessions, the next one's going to be on evidence-based ideas for opioid abatement funding. And then we're going to have one following that, the media and addiction reporting, and then also a transformational employment. So those are our upcoming sessions that as soon as we get dates, I'll give you some information about. And I just want to thank everybody for being here. We really appreciate you coming to this session today and hope to see you in future sessions. Have a great day, everybody.